Hello, it's 5 o'clock sharp. I welcome you all to this webinar lecture on urticaria. Today is World Urticaria Day, as you of course know, and it's my great pleasure to give this lecture for you. So this year we think about actually who cares about urticaria. Of course, we do and you care. And I would like to share with you what is new in urticaria and why do we actually urticaria have, and what is the current treatment options. So over the past years, some things have changed and we'll come to this. So as you know, at Urticaria Day, we have the urticariaday.org webpage. If you haven't visited this webpage, please go there. There's a lot of useful information and it's fun to look because there's all over the world activities going on today and tomorrow, and some started even yesterday, making pictures, making activities all around urticaria. As you can see here, the urticaria network has quite expanded. So all over the world, in almost every country, we have so-called ucare centers. So ucare centers are hospitals with dedicated urticaria experts which are educated to diagnose and treat patients with chronic urticaria properly, and they all rely to the current diagnostic and treatment standards. So this network is still expanding. Actually, every week we have another ucare center applying to become a center of excellence. There is some requirements these centers need to fulfill. People from Galen, the global network of asthma and allergy, actually go there, visit these centers, and make sure that they all do properly in diagnosing and treating urticaria. So making sure that we all work on the same standards and that patients all over the world are diagnosed and treated the same way. Let's come to the disease. So you may know that urticaria actually consists of these skin lesions, which we call wheals. It's like a nettle rash. So these swellings on the skin, they can burn, they itch, but they are not long lasting. They develop very quickly and within some minutes, or let's say an hour or two, the longest, these lesions disappear and the skin looks normal as it looked before. Together with the hives, some patients also develop angioedema. Angioedema are swellings, mostly located in the face, on their lips, on their eyes. Some have it on their hands or on their feet. And it could be either or it could be even both. Some patients also suffer from angioedema and hives. Important for patients suffering from angioedema only is that there's differential diagnosis. There's rare forms of angioedema, so-called hereditary angioedema, which must be excluded. But if this is excluded, which is done by a simple lab test and some questionnaires, these people frequently have a family history of these swellings, so it's a familial disorder. And if this is all not the case, then angioedema only also is a form of urticaria and therefore is similarly treated as urticaria with hives. So affected from urticaria are men and women. It's a little bit more women than men. It's about 3 to 1. It affects people of all age, the very young and the very old, and it can actually occur all over lifetime. Men are not the only beings that can suffer from urticaria. Also, some animals can suffer from urticaria. For example, a horse or even dogs can develop wheals and suffer from chronic urticaria. Urticaria itself is actually one of the most frequent skin diseases we know. So most of the urticaria forms are acute. And acute forms are not so complicated. They just last for a couple of weeks, no longer than 6 weeks. But this acute urticaria is experienced by almost 1 out of 4 people during their lifetime. So it's a really, really common and frequent skin disorder. But as said, the acute forms, which come mostly in line with uncomplicated infections, for example, of the upper airways, it's very annoying, but it needs symptomatic treatment and it will resolve within a couple of weeks. More complicated are the chronic forms. And the chronic forms are actually disabling because here the wheals or the angioedema and the itch can persist for months or even years in some patients. The problem is that in spontaneous urticaria, chronic spontaneous urticaria, these symptoms are unpredictable. So you never know when you will develop wheals or even angioedema the next time. So for patients suffering from this disease, this is really a very, very annoying disorder. And as said, it lasts in some patients even for longer than 10 years. Here you can see, I have to apologize, this is still in German, but I explained to you. So the blue, the 50%, is like up to 2 years. And the orange one is patients, so about 30 to 40% suffer from the disease between 3 and 10 years. And still 12.5% have the disease for more than 10 years. So you can imagine what that means, having almost every day itchy wheals or even angioedema once a week or more frequent for such a long time. So this really makes the disease chronic, and the problem here is that we need to make sure, do we have hives, do we have angioedema, is there any time course when they appear, where they do appear, how active these lesions are, and how frequent the symptoms come. So to explain to you what is actually happening in the skin when a wheal is developing, we just look a bit underneath the skin. So in our skin, or actually in skin of all of us, there's a specific cell type which we call the mast cell. It's actually the cell that is also eliciting all kinds of allergic reactions. So when we have a hay fever, for example, these cells get activated by the pollen and they degranulate and they release a substance which is called histamine. And in urticaria, this is not pollen activating these cells. Actually, it's not even an allergy, even so it looks like an allergy. For many years, we have thought that people having chronic urticaria are allergic to something in their environment, but they're actually not. And for the real cause, I'm going to explain you a little later. So this histamine, which is released from the mast cells, find actually receptors, so sensitive structures on 2 anatomical sites in the skin. One is the blood vessels, and when histamine comes to the blood vessel, 2 things are happening. First, the blood vessel gets wider. That's what we see on the skin as redness. And the blood vessels also get a bit leaky, and therefore just the water from the blood, not the cells, the water mostly, can evoke into the tissue, and that produces the swelling. And also the sensory nerves in the skin have histamine receptors, and when the histamine come to the sensory nerves, the nerves get activated, and this is what we perceive as the itch. So here you see this blue ball. This is all water coming out of the blood vessel, actually producing the wheal and producing the swelling on the skin, which then imposes as the wheal we can see on the skin. Unclear is, or unclear was for a long time, what is the mast cell activating factor in urticaria. As said, it's not an easy allergy, and we were asking for a long, long time what is actually the triggers and causes of the disease. So for many years, it was believed that intolerance reactions, for example, against specific food components or drugs or even substances coming from bacteria by chronic infections, may produce mediators or factors that are able to activate the mast cell. Indeed, we have seen a simultaneously occurrence of chronic infections in some patients suffering from chronic urticaria. Some patients actually are intolerant to specific food components. So many patients have underwent specific elementary diets. But what we have learned is that actually by doing the diet, this very infrequently really resolved in the elimination of the wheals and the control of the disease. So this is a little outdated now. It can still as a trigger modulate the disease, but we are not thinking any longer that food components or chronic infections or medications are the actual cause of the disease. What we have learned in the last years is, and now don't get confused, urticaria patients are indeed allergic. They have allergy antibodies, like a patient suffering from hay fever. But these allergy antibodies are not directed against anything from the environment or against things that come from the environment. These people suffering from chronic spontaneous urticaria have allergy antibodies which are directed to body-own structures. So you can say they're allergic against themselves, and we call this phenomenon autoallergy, which means we have a self-produced allergy of our immune system against body-own structures. So to explain this a little bit more in detail, our immune system is educated to produce these kind of antibodies. These Ys you see here, these are antibodies, and we have antibodies of different kinds. So there's antibodies that protect us from viral infections or bacterial infections, but there's also antibodies that are directed against something which we actually don't want them to direct it against. So autoimmune diseases are also caused by these antibodies, in which antibodies also recognize body-own structures. So mostly, or in most of the autoimmune diseases, these antibodies are not the allergy type of antibodies. The allergy type of antibodies is called the IgE, immunoglobulin E. And most antibodies we have belong to the group of immunoglobulin G. These are the ones protecting us from infections, and the immunoglobulin E, they produce or they make us allergic. And chronic urticaria patients have in their blood a lot of immunoglobulin E, which is directed against self. So what happens actually is that these antibodies bind to the surface of mast cells, and this can happen in two ways. Either the IgE binds to the mast cell, and there is an autoallergen. So this structure in the body which is recognized by this antibody, and if this comes and binds to the IgE which sits on the surface of the mast cell, this leads to the activation of the cell. Now a little bit more complicated, there's also IgG antibodies, immunoglobulin G antibodies, so where we have most of, and these could be directly directed against the receptors of mast cells which bind the IgE. So it doesn't actually need the IgE to activate the mast cell. So this is two different mechanisms, not necessary to know them in detail. But what I want you to know is that both mechanisms are actually autoimmune or autoallergic. So it is coming from our own immune system. It's a dysregulation of our immune system, and it does not need anything from the outside to cause mast cell activation and histamine release and the elicitation of Weil's itch or angioedema. So in chronic spontaneous urticaria, as said, the symptoms come and the symptoms go. And this may happen once a day. This may happen several times a week. And there's no specific trigger. You know, there's also, besides the chronic spontaneous urticaria, which we call the form where the wheals or the angioedema just come without any obvious reason, there's also so-called inducible forms of urticaria. So these patients develop wheals and or angioedema and itch due to a specific, mostly physical trigger. This could be cold or heat or sunlight or friction. This is a little bit different. And to be honest, we assume that similar mechanisms in inducible forms are also relevant for mast cell activation, but we are not so sure yet, because how can you have allergy antibodies against cold, for example? But maybe cold produces any structural conformation of some structures in our body that then serve as an autoallergen. But we're not going into detail here. Let's stay with the spontaneous forms. So the immune system produces allergy antibodies against body-owned structures, and this then causes the disease. And here you see some examples, and the wheals just come without any obvious reason by its own. So as said, we are not so in favor anymore of the trigger system. So in some patients, they really experience that food components or specific drugs like NSAIDs, for example, painkillers, they could modulate the disease in a sense that it aggravates the severity of the disease, or it brings the wheals to come. But this is not the reason why people have the disease. It is just an elicitor of the symptoms. So for, let's say, the last 20 years, we have really thoroughly investigated patients, did a lot of diagnostic tests, trying to identify these triggers. But what we have learned is that, as said, triggers are only relevant in a minority of patients. They are very complex to identify, and mostly elimination is difficult or even impossible, because you need to eat something, you may need a medication, or if it's a chronic infection that causes or triggers your symptoms, how can you avoid in winter to have an infection of your upper airways, which could then make your disease worse? Additionally, when we try to eliminate these triggers, for example, by very strict diets, we have learned that it's almost impossible, and in really not a lot of patients, it was possible to completely control the disease and to completely eliminate the symptoms by only avoiding the trigger, actually leading to the fact that there must be something else. And this is how the concept of autoallergy was born. Actually, we have learned this by a new treatment strategy. You may have heard of the anti-IgE. This is one of the best treatment options we have available at the moment for the treatment of chronic spontaneous urticaria. So it was initially an asthma drug used for the last 15 years. And there are some patients having both diseases, asthma and chronic spontaneous urticaria. And actually they got anti-IgE, so an antibody directed against these allergy antibodies and blocking their function. They were treated with this drug to control their asthma. And what was observed was that even before the asthma was controlled, their urticaria was controlled. So from this on, urticaria, well, has a renaissance of indeed having an allergy component, and it took us some more years to identify this autoallergy mechanism. So I have told you that this is produced by our own immune system. So therefore, this mechanism or this phenomenon, unfortunately, cannot be eliminated. So therefore, we need to apply very, very good and controlling treatment mechanisms to control the disease. And I come to this in a moment. Saying that, we now having the concept of autoallergy of the real cause of chronic spontaneous urticaria, it means now that there's actually no need for a lot of diagnostic tests. So we recommend in the international guideline and to the doctors we teach how to diagnose and treat urticaria to not, as we did years before, a lot of diagnostic tests in all patients. Basically, it's very minor. So we do a differential blood count and some inflammation markers, basically to exclude differential diagnosis, because there's some also rare diseases that look like urticaria, but they're actually not urticaria. And this is what we do the diagnosis for, or the diagnostic measures for, to exclude these very rare differential diagnoses. Not more. It makes indeed sense to do some more examinations when we have a specific suggestive trigger. So some patients really realize when they have eaten specific foods or when they have taken specific drugs, their symptoms get worse. And yes, in these cases, we may look for the trigger, because then identifying and trying to avoid the trigger may decrease disease activity, but will probably not eliminate and control the disease completely. So our primarily our goal in treating the disease is actually we need to control the symptoms. We want our patients to be off hives, off angioedema, and off itch. This is a treatment strategy which does basically not cure urticaria. So by the drugs we applying for treatment, it does not change the disease course. It is just blocking the symptoms. But fortunately, we have so well tolerated drugs that are very, very low in side effects that it is possible to do such a treatment for many, many years. Basically, we have to treat the disease as long as it's there. And we can do this because chronic spontaneous urticaria will go away. This is 100%. The problem is we just can't predict if a patient will suffer from chronic urticaria for a couple of weeks, a couple of months, or a couple of years. So we treat the disease, we block the symptoms. Our goal is to completely eliminate the symptoms by these treatment strategies. And once in a while, we just check if treatment is still needed. And if symptoms come back, then we reintroduce the treatment, and we do this as long as the disease is there. So let me show you how we treat urticaria. This is actually a very, very simple algorithm, which is in the international guideline. So I have told you that the most prominent factor that is released by activated mast cells is histamine. Histamine is producing the swelling, the redness, the itch, so everything we see in urticaria. We have drugs that we call antihistamines. This is the same people take for allergic rhinitis, so for hay fever. It's also mediated by histamine. And this is always the first step. We try simply giving them an allergy pill and look how the symptoms respond. The next step would be that we increase the dose, because not all patients will be sufficiently or the symptoms will not sufficiently controlled by a single dose of antihistamine. And if even this doesn't work, there's more options. The omalizumab is the anti-IgE I have talked about before. And in some patients, even this doesn't work. So there's other drugs available like cyclosporine, but cyclosporine is not an easy drug. Cyclosporine is very effective, but also causes a lot of side effects. And therefore, this is not a treatment option that could be easily done for many, many years, which we may need to control the symptoms over a long time. So as said, this treatment is meant to avoid the symptoms. So these treatment strategies have to be taken continuously. It should be a prophylactic treatment avoiding the appearance and the elicitation of the symptoms, not treating the symptoms. So the strategy is to put a patient on a continuous treatment that is able to just block the symptoms that they will not appear. So let me go a little bit more in detail. As said, first step is a single tablet once a day of a non or less sedating antihistamine. We call them second generation. There's old ones that make you very tired. There's newer ones that have not so much the problem of making us tired. And when we do this, well, yes, there's some patients that are sufficiently controlled by this, but it's not all. It's about 1 out of 5 in which the symptoms are completely controlled by simply giving a single pill of an antihistamine a day. So as said, second step is we give more of the antihistamine. There's a lot of clinical trials out there showing that giving more antihistamine is more effective, but is not causing more side effects. So it's safe to do, and it's actually the most consequent second step. So when we increase the dose and it's safe to take up to 4 tablets of an antihistamine, second generation as antihistamine per day, well, a lot of more patients get off symptoms, as you can see here. Let's say a little bit more than half, between 50 and 60%, can be sufficiently treated by giving them a higher dose of antihistamine than usually recommended. But as said, we have good data that this is safe and that this is effective, and this is a treatment option that can be taken by patients for many, many years. So if this doesn't work, you see there's the red guys here, still many patients, even so taking 4 tablets of an antihistamine per day, still have symptoms. So then we come to the third step, which is the omalizumab, which is the anti-IgE. There has a lot of clinical trials being conducted over the last years showing the efficacy and also safety of this drug. This drug is different from antihistamines. First of all, it's not a tablet. It's an injection, but it's only received once a month, so every 4 weeks. But we need 2 injections actually, which are given beneath the skin, so as a subcutaneous injection. Why do we need 2? Well, we need a specific dose, and unfortunately only half of the dose we need to control the symptoms in most patients does not fit into 1 syringe. So it needs to be 2 injections, unfortunately. But it's like, it's like a vaccination. It's not a big deal, and most patients take this very easily because they benefit really from the drug, because it controls the symptoms, even in patients that are not sufficiently treated by high-dose antihistamine. So you see, it's about 80 to 85% that get really off symptoms by this treatment. And it's also so safe that many patients are on that treatment for many years now. As said, it has been known before as a treatment for allergic asthma, in which even higher doses are used. So there's no safety concern in also doing this treatment for a long period, even for years if it's needed. So we are, with this treatment option, more or less on the end of the algorithm. As said, next step would be a drug like cyclosporin, which causes a lot of side effects and which we are not in favor of use for a long time to control urticaria symptoms. But as said, it's about 10 to 15% that do not respond to the omalizumab, to the anti-IgE treatment. We don't know why this is, because we think in all patients the autoallergic or autoimmune mechanism has a role, but maybe we need to learn more. Maybe there's additional mechanisms in a minority of patients that are not connected to the allergy antibodies, immunoglobulin E. So the anti-IgE, the omalizumab, can't work in them. So what are we doing in these patients? Well, and this is future. We are not giving up. Research is going on. So our future aim has to be also making these patients under control of their symptoms that do not respond to the current available treatment options. And what we do, yes, of course, we do clinical trials. There is actually quite some new substances underway and under clinical investigation at the moment. So we think that maybe in 2 or 3 years we will even have additional treatment options available that are as effective as the IgE and also work in the patients that do not respond to the anti-IgE treatment. So these clinical trials mostly get conducted in different places on the planet. So we try to have as many ucare centers participating in these clinical trials as possible. So for us, I can only mention 2 of the German study centers here. So, we sit here at Charité in Berlin, and we have a partner urticaria clinic in Mainz, a city close to Frankfurt in the middle south of Germany. So even so, this is German centers. If you are interested in participating in a clinical trial, just get in contact with either us or our colleagues in Mainz, and we can inform you about clinical trials that are ongoing at the moment and can even give you information on where a participation in a specific clinical trial is possible in different countries and even on different continents. So we are almost at the end. Coming to the summary, I'm gonna say, I have told you that urticaria is a very common disease. It's even the chronic form still is one of the most frequent skin diseases we know. We estimate that about 1% of the general population suffers from chronic urticaria at the moment. So this is 1 out of 100, and there's not many diseases that are so frequent occurring than urticaria. So it's a big problem. And therefore we need the good treatment options because, our school children can't really learn having urticaria. We can't really work having urticaria. Life is no fun with having urticaria. Therefore, these very effective treatment options are really needed and are really beneficiary for the patients suffering from urticaria. So as I said, the most common form is the chronic spontaneous urticaria. A little more unfrequent, the inducible forms I have you reported on. Triggers are not so important anymore as we have believed some years back, but in some patients there is still relevant triggers. They may worsen the symptoms or the symptom severity, but it's not the underlying cause of the disease. In recent years, we have identified autoallergic mechanisms produced by our own immune system, which is the underlying cause in most patients suffering from chronic spontaneous urticaria. So our treatment strategy is to do a prophylaxis treatment. So not waiting for the symptoms to come and then treat them, having a continuous treatment to avoid the occurrence of the symptoms. This is the strategy that works best. And the aim is always the complete elimination of symptoms, so complete control. We want you, even so you have chronic spontaneous urticaria, don't notice that you have chronic spontaneous urticaria. So no wheals, no itch. That's the aim we request for the treatment of urticaria. And I've showed you the algorithm. So it's a step-by-step or a step-up approach. We start with antihistamines, single dose. As usual, if this doesn't work, we give more of the antihistamines, up to 4-fold. And if this doesn't work, we go into the anti-IgE. And if this doesn't work, which is the case, unfortunately, in some patients, then we go to the novel treatment options currently under clinical investigation in clinical trials. So as said, by now we have at least managed to achieve complete control of the disease in about 80 to 85% of patients. This is great because, let's say, 10 years ago, it was only 20 to 40% we were able to achieve this. Now it's 80%, so we are on a good way, and we are confident that we also will find good solutions and very effective treatment options for the remaining 15 to 20% of patients that still suffer from their symptoms despite the currently available treatment options. So as said, this is a huge research effort which many centers on the world participate in. The ucare centers actually meet once a year. We will also have this year in December a meeting where the experts from all over the world meet. We updating us on our experiences, we updating us on the clinical trials, and we even discuss novel treatment options that may also beneficial to investigate in chronic urticaria. So you can imagine this all takes time, this all takes effort, and of course this all costs money. So if you see any chance and you want to help us because you care about yourself, you care about maybe your family members or your best friends that suffer from urticaria. So I'm not gonna really deeply advertise this here, but if you want, so there is a chance on the urticariaday.org website. You see here in the middle the button donation. So go there. There's many things how you can help us, even by donating something or even by doing something. So if you have time today, get in contact with others, do something, hold a sign, Chronic Urticaria Day, make a picture and upload it to the website. This makes awareness, and awareness for the disease is also very important, because first we need our patients to know what is going on and what current treatment options are available. We need our pharma industry to be aware of the disease, because only if they know what chronic urticaria is and how many people are affected and how big the problem with the disease is, they will go into developing new drugs and new treatment strategies. So we also need their help. You can become a supporter. There is also supporters. So if you have a company or you have an allergy center, or you are somehow connected to a patient organization, let us know. You could be listed here as a supporter of the Urticaria Day or a supporter of the ucare centers. Everyone is welcome. We like the network to grow because urticaria is a worldwide problem, and therefore it also needs worldwide activities. So you see, I have said in the beginning, in many countries we already have ucare centers. Excuse me, but you see still some, well, empty areas. So if you by chance come or know anyone from a country, so you see in the US there's still in the western part of the country not many registered ucare centers yet. In Canada we miss actually a coverage of centers. In Russia there's not many centers available now. So if you come from one of these areas, please talk to your doctor or to your urticaria specialist and ask them if they are not in favor of joining the network and get connected to other experts on the world, which in the end will benefit all urticaria patients in this specific regions. So now we have a little time left for your questions. So you know that you can actually use the chat. Please just type in a question if you have a question. I should have mentioned this at the beginning. Please apologize, I forgot. So if you now have a question, please type in, and then we have like 5 more minutes to answer your urgent questions. Okay, yes, there's the first one. So, is the anti-IgE treatment Xolair? Yes, Xolair is the trade name and omalizumab is the name of the drug. So it's the same name for the same drug. That is right. So another one says, I joined late. This webinar will be available? Yes, we have recorded it. So either later today or the latest tomorrow from our time, because it's evening here in Germany, we will have uploaded the webinars, the German and the English one, at the uday website. So please check back tomorrow and you will see the whole presentation and my voice again if you want to repeat or if you started late. So I have heard there are some side effects. What is the likelihood? So I think you mean side effects of the Xolair. So honestly, we not observe side effects so often or in so many patients, and at least not severe ones. So there is, let's say, a history and a fear that omalizumab itself could cause an allergy, an anaphylactic reaction. This may have happened in earlier years in patients that were treated with omalizumab for their allergic asthma. So let's say there is a big difference because between asthma patients and urticaria patients. So asthma patients are real allergic patients. Their immune system is prone to react against triggers and substances and elicitors from the outside. And this may even include drugs. So it's very rare. I think it's only 2 or 3 cases within the last 20 years that have been reported. But well, yes, one anaphylactic reaction is one too much. So people have put their eyes really intensively on that. And I'm not lying by saying that within the last 10 years, we have not observed an anaphylactic reaction to the drug in urticaria patients. It's even meant to be so safe that by the end of last year in Europe, the omalizumab treatment was licensed and registered for self-administration for urticaria patients. So the first 3 injections or the first 3 per 2 injections should be observed by a doctor, and if this is well tolerated, which is usually the case, patient can get the syringes at home and do self-administration, not even needs to go to the doctor. So you see, this is the common view on omalizumab and its safety. So there's no severe side effects. There's some minor side effects. So there's some patients that experience when they receive the injections, well, they sense it. They may have, they may feel like they have a little fever, or they have some joint pain, or even a headache. But this usually does not last for longer than 2 or 3 days. People help themselves by taking paracetamol or any painkiller they tolerate, and they go over it because they're the benefit they have in controlling the urticaria symptoms are much greater than having these couple of days of a minor weird feeling. The more patients are treated, the more side effects, of course, are considered to be maybe associated with Xolair. So in very infrequent cases, we have a longer lasting evidence of joint pain. Some people report on an increased hair loss, so not completely losing their hair, but they realize that there's something happening with their hair. So honestly, the mechanism by which this could happen is not clear. We are now started investigating this, as said, it's very, very infrequent. Let's say maybe 1 out of 100 patients that reports on this. And there's many other possible reasons for having joint pains or hair loss. So it's not yet clear if this is a real side effect of the drug, or if this may have another reason. But of course, we take this seriously, look into this, observing and follow up these patients, and try to figure out what is going on here. So there's actually here a note that one of our participants in the audience have hair loss when taking a Xolair, and adding biotin supplement has helped. Well, this is a great idea. Thank you for this. So we will try this in our patients as well. We have tried. We also tried other things and excluded other possible causes of hair loss. Let's say in very, very infrequent cases, we even were forced to get the patients off Xolair because nothing really helped, and we didn't see another reason. But as said, this is the minority of patients, and we're looking deeper into this. But thank you for this comment. This is probably something patients having the same experience should also try. Biotin is safe. Biotin is a supplement. So when people experience a slight hair loss under Xolair, this may be the first option to try, and if it helps, then it may even make the patients able to stay on Xolair, which is really important. So last question here is, does Xolair conflict with other medications? Not that we know. The reason for this is, Xolair belongs to the group of biologics. Biologics are antibodies, meaning the drug actually looks very similar to the antibodies our immune system or our body produces. It's just directed against a specific structure we want to target, in this case, the IgE. Meaning that there's not a big chance for the drug to do other things than just binding to the IgE and avoid its function. Since the medication is very similar to something which our body produces by himself, there's even no big problem of eliminating this. As our body does with other antibodies, even the omalizumab, the anti-IgE, is just excreted by a natural mechanism, and it's not harming the liver, it's not harming the kidney, and it's basically not interfering with other drugs by this, because it's not competing to eliminatory mechanisms of other drugs, or it cannot influence the mechanism of action of other drugs. So in this case, also omalizumab is very, very safe. So yeah, I have missed this one, and this will then be the last question we answer. Respond to urticaria vasculitis question. I'm in misery. Okay, I have to go up. Where was the urticaria vasculitis question? Well, I'm not sure if I can find your question, but maybe I can say something about urticaria vasculitis itself. Here it is. Is treatment different? Yes, it is different. So urticaria vasculitis, the only thing urticaria vasculitis shares with chronic urticaria is part of the name, because this is one of the rare differential diagnoses. It looks similar to urticaria because patients suffering from urticaria vasculitis also will show hives on their skin, but the mechanism by which these structures that look similar to hives or wheals are produced are completely different. There's even a clinical difference. So the hives that are occurring in urticaria vasculitis are mostly long-standing, so the single wheal will last mostly for longer than 24 hours, which is never the case in chronic urticaria. Here the wheals disappear within 1 or 2 hours. It may be that there is another wheal right next appearing during that time, but the single standing wheal will not last longer than 24 hours. And there's other symptoms that may additionally occur in urticaria vasculitis, like joint pain, for example, or even other symptoms. So honestly speaking, the underlying mechanism of urticaria vasculitis are not as well known as the underlying mechanisms for chronic spontaneous urticaria. But what we know is that IgE is most likely not involved, so the omalizumab most likely will not help here. Here we really need to go to other drugs that modulate the immune system in that way that the self-produced inflammation, which is actually the not the underlying mechanism, but the cause that people suffer from chronic, not from chronic urticaria, sorry, from urticaria vasculitis, needs to be controlled. So it's not an easy task, but it's possible. If it's not so clear whether it's urticaria vasculitis or a very severe form of chronic spontaneous urticaria, because making the difference between the two diagnoses by the diagnostic tests we have is not always 100%. So urticaria vasculitis is usually diagnosed on a skin biopsy, where we see, or where the pathologist sees specific pathological changes in the skin. But as said, there's not always so clear. So even if urticaria vasculitis is suspected, omalizumab may be given a try, because it could even be a very severe form of chronic spontaneous urticaria. And if it helps, then it's probably the best and safest treatment options you can do. And in the end, you will actually not have urticaria vasculitis. You may even have, or rather have, a very severe form of chronic spontaneous urticaria, which then also can produce long-lasting wheals. If it's real urticaria vasculitis and it's diagnosed by skin biopsy, and even some other factors that are checked on the immune system, then there's other treatment strategies available. Not so many and not so safe ones as we have for chronic urticaria, because it's a rare disease. So we need to get our hands or take our hands on drugs that need continuous monitoring, control of blood counts in some instances, because we need to control the side effects these drugs may have. But many patients, even with urticaria vasculitis, can be sufficiently treated and their symptoms can be controlled. Most urticaria experts are actually also experts in treating urticaria vasculitis, because the diseases are so similar. So please also get in contact with an urticaria specialist. There is also a ucare website where all urticaria centers of excellence and reference are listed. Look if there is some nearby to you, and this is the right people to ask if you will not find sufficient help by your private doctor or the doctors in your environment. All right, we have to close here. I thank you very much for attending this webinar. Thank you very much for your questions. I see there's a lot of interest, and please spread the word, make awareness, make a picture of yourself or of anything that is related to urticaria, post it to the website, and as said, the webinar and this lecture will be available tomorrow. So even if you or your friends were not able to participate now, these patients can, of course, look at this lecture then at the uday website. Thank you and goodbye.